Hey everyone, and welcome back to Breaking Down Nursing. Today we're going to talk about the difference between SIADH and DI. Have you ever mixed these up before? Well, you're not alone. It's probably one of my most commonly asked questions during tutoring sessions. So let's break down what's going on. Everything revolves around antidiuretic hormone, aka vasopressin. Now remember, antidiuretic hormone is produced in your hypothalamus, but remember, it's stored and released from your posterior pituitary. Now remember, antidiuretic hormone's job is to regulate our body water balance, helping the kidneys to reabsorb water when it's needed. Well, let's start with SIADH, which stands for Syndrome of Inappropriate Antidiuretic Hormone. This means the body is releasing or acting like it has too much antidiuretic hormone, or ADH. ADH tells the kidneys to reabsorb water. So in SIADH, the patient retains free water, which dilutes the blood, and leads to low serum sodium, called hyponatremia. So some causes would be lung disease, head injuries, brain tumors, especially a pituitary brain tumor, small cell lung cancer, and some medications, like antidepressants and some anticonvulsants. Again, this leads to too much antidiuretic hormone, too much water retained, too little sodium in the blood, and concentrated urine. So let's move over to DI, or diabetes insipidus. This is a lack of antidiuretic hormone. Now, as a side note, even though there's diabetes in the name, it has nothing to do with blood sugars. So always keep in mind that diabetes mellitus has to do with your insulin and glucose levels, but diabetes insipidus has to do with your antidiuretic hormone and water. They're not the same. So some causes of diabetes insipidus: brain surgery, especially a transsphenoidal where they take out a pituitary tumor, meningitis, genetic disorders, lithium, chronic kidney disease, and sometimes polycystic kidney disease. This then leads to too little antidiuretic hormone, which means that you have too much water loss, making your urine very dilute and almost sometimes clear. With the loss of so much water, you have too much sodium in your blood. So let's put these on a chart together based off the sodium level, serum osmolality, urine osmolality, and then urine output. For SIADH, we have a low sodium level because we're diluting, because we're retaining water, which means our serum osmolality, which is the concentration of our blood, is low because we have more water than salt. On the other hand, since we have low urine output, we have a high urine osmolality because the urine is very concentrated because of low urine output. On the other hand, DI is the other side. Diabetes insipidus, we're losing too much water because we have too little antidiuretic hormone. And so our sodium level goes up because we're voiding out all of our extra water. Our serum osmolality, or the concentration in our bloodstream, goes up because, again, we're losing too much water. Our urine osmo goes down because we have clear urine and it's very, very dilute. And our urine output goes up. I've seen patients to have 250, 300, 450 an hour sometimes if they're in diabetes insipidus. So what's the risk of having these diseases? With SIADH, we can have cerebral edema or brain swelling. So some of the treatments we'd always have to treat the underlying cause. What's causing the problem? Some other alternatives are restricting free water, because again, they're very dilute. Careful sodium correction. Sodium is one of those electrolytes that can't be corrected too quickly. We can cause demyelination of the myelin sheaths. So sodium correction has to be carefully done over time. And then of course, sodium replacement. On the other side, diabetes insipidus can cause things like cellular dehydration because we're losing so much water volume and our sodium goes up so high. Treatment for DI also depends on the cause. Sometimes we measure things like DDAVP, or vasopressin, is a synthetic version of antidiuretic hormone, or we water replace for the water volume loss. So remember, an easy way to remember it is SIADH is too much antidiuretic hormone, and DI is dry inside, too little, so we lose volume. As always, thanks for watching. If this helped you finally separate SIADH from DI, subscribe and save this video for later. Drop a comment with the next endocrine topic you want broken down. Have a good one.